Hello again from Cardiovascular Innovations 2017 in Denver, Colorado. My name is Jaler Sandoval from Mayo Clinic, and I'm happy to be here with Dr. Zankar from Presbyterian Heart in Dallas, who has a case for us.
Good morning, everybody. First of all, I would like to thank Cardiovascular Innovation Administration staff, especially Dr. Banerjee and Dr. Blakis, for giving me this opportunity to come to Denver and present this case. I would also like to thank Dr. Yader for hosting me today. We will be talking about a case that involves complex unprotected left main PCI with Impella hemodynamic support due to high-risk features, and a procedure that involves rotational atherectomy and two-stent technique of the distal left main bifurcation. I currently work at Presbyterian Heart and Vascular in Plano, and this patient was an 84-year-old female patient hospitalized at an outside hospital for a non-STEMI and found to have a reduced left ventricular ejection fraction, 45 to 50%, although when she presented to our hospital, her ejection fraction was more like in the 40%. In the outside hospital, she didn't undergo any invasive procedures, but in our heart catheterization lab, we did left heart catheterization, and we found that she had significant calcified distal left main disease that also involved the ostial left circumflex with a very high-grade stenosis. Definitely with this elderly, frail patient, we decided to have a prolonged discussion with her and her son, and we offered her the options. And since she had left main PCI, where bypass surgery has been shown over the years to be the primary go-to procedure, she decided to decline this option given her age and her frailty, and after involvement of the cardiothoracic surgeon, they also agreed with her choices. So we decided to respect that choice and proceed with the percutaneous option. As we see angiographically, a very high-grade distal left main, 84-year-old, so we expect angiographically to have a lot of calcium in that bifurcation. You can also see in the cranial shot that the ostium of the left circumflex has a very high-grade stenosis and is about to really shut off. Her LAD otherwise was okay, her RCA was okay, so we're faced with a complex bifurcation, but otherwise not a very high syntax score given the lack of disease in the LAD and the left circumflex. So we decided to offer this patient Impella support. And the reason we decided to do that was based on, one, patient factors that involved the age of the patient, the frailty of the patient, two, the complexity of the lesions, and that involves an unprotected distal left main with an ostial circumflex, in addition to the need for rotational atherectomy. And third, the presentation of the patient, which involves somebody with an acute coronary syndrome, with a depressed LV ejection fraction. And these are the main factors usually that dictate the high-risk PCI option. Now, deciding on her Impella support, we were faced with some problems. She really had tortuosity of her aorta, as well as severe sort of scoliosis in her spine. You can see that the aorta is really small, and also comes at an angle. The left iliac is very tortuous, comes at a really extreme angle from the aorta. The right iliac is mainly a straight shot, so that's why we decided to put the Impella from the right, because we thought it was a straight shot to the heart. from the left, there was a severe angulation, and we decided to do the intervention from the left side. We put a long 7 French sheath and proceeded with PCI. So again, before we started, we measured the left ventricular end-diastolic pressure, and her LVEDP was compensated at 15. We used a pre-closed system with 2 pre-closed suture devices on the right side for the impella. And we also used a 14 French cook flexor sheath over a stiff wire to provide us good access to the aorta. After this, we inserted an impella 3.5 and repositioned on the LV and noticed very good flow. In regards to the intervention, we were faced with some complexities in that we had a retroflex left circumflex, and the decision was made to do rotational atherectomy into the circumflex rather than into the LAD, because we were worried that if you did rotational atherectomy in the LAD, we might lose the circ. And we thought that the osteo-LAD was not involved. Wiring the circumflex was extremely difficult. We tried with whisper wire, run-through wire, fielder wire, and we almost lost flow in the circumflex, as you can see in the next shot. But surprisingly, because of the impella support, the patient tolerated this well without any chest pain or hemodynamic consequences. And this is where the impella came in to help us, because had this had happened without the impella, I think we would have been in great trouble with this patient with distal left main, with her circ shutting off. After multiple wiring, we decided that just plain wiring was not going to work, so we used a venture guide catheter that allows angulation, and we finally were able to pass Fielder XT wire into that left circumflex and gained access. And we next exchanged over a fine cross catheter into the rotablator wire, and we were able to basically perform rotational atherectomy with a small burr, 1.5. Reason being is we didn't want to go with a high burr. We just wanted to modify, given the complexity, especially the angulation of the left circ. We didn't want to do any cause any major dissections. And I'll show you the result after the atherectomy here. We had a good result from the atherectomy. We felt we modified very well. And so, and then next we decided to proceed with percutaneous intervention. We ballooned the circ with a compliant balloon to 512. And then we had wired the LAD with a BMW wire for protection. After that, we decided to proceed with stenting. We stented the circumflex first, and then we did a TAP procedure and stented the LAD, and finished with a kissing balloon intervention. We always IVUS after left main intervention, and the IVUS was satisfactory with a no residual dissection, and also well opposed and well expanded stent in the left main, and I see minimum luminal area of 10.2 millimeters squared. This is the final result, and patient did very well with follow-up after 3 months, showing that no clinical chest pain or hemodynamic instability or issues. She was performing her ADLs and went to cardiac rehab without issues. Of note that after the procedure, we removed the 14 French sheath and did use the 2 perclosed devices and closed that arteriotomy without any complications. We closed the other site with an 8 French angioceal, and the patient went to her telemetry bed without complications and tolerated the procedure well. Thank you very much.